Hello, can we start, please? You have done your job of getting them. Okay, you have declared. Okay, friends, I think as we would like to conclude this session as planned, say around few minutes here and there, let us do that. Please, now let's call for the next session, please, next presentation, please.
Okay. The next presentation will be Professor Guy Kegels. He is working at ITM, Institute of Tropical Medicine in Antwerp, at the Department of Public Health. He got his MD at the University of Antwerp in 1976 and his diploma in tropical medicine in 1977. Then from 1979 till 88, he had a few long-term assignments related to health service and project management in the Comoro Islands and Mali. And then he did his PhD on health system dealing with human African trypanosomiasis. Then since 1989 he works at ITM and he teaches and does research on health services organization. The title of his talk will be Vertical Analysis after some decades, about 20 years of experience, I would say. It's about his extended experience with the vertical analysis exercise, which is given to postgraduate and MPH students, with the specific question of which lessons he has learned from this. The floor is yours.
Thank you very much. Yes, this time it works. Thank you very much, Katja, for this introduction. So as you can see, if you can read, and most of you can, I think, this is, the title of this talk is Vertical Analysis between inverted commas after some decades of experience. Now, why is this between inverted commas? Well, actually, it's very simple. This is one of the idiosyncrasies of the Department of Public Health at the Institute of Tropical Medicine in Antwerp, that we call this a vertical analysis. You will not find this word anywhere else, as far as I know. We will soon see what it is, but it is in, let's say, in the context of what this session is about, planning and evaluating disease control interventions. This is a method to plan. It is, as we are a teaching institution, it is somehow, of course, a didactic tool. It is an exercise for our students. And by the way, many of our students are not, well, already have quite a bit of experience, field experience. It is an exercise in critical appraisal of available evidence. And if you go a little bit deeper into that, it is, yeah, you could call it double loop learning. It is about learning to know how we know, learning to learn how to learn. At least that is the secret aspiration, let's say, of those who are trying to accompany the students in this exercise. It's about knowing what to do, knowing how to do it. But in practice, what we ask students to do is to make a systematic analysis of a health problem, taking up the role of, for those of you who know that, Mintzberg's technostructure in disease control program formulation. In other words, this is the task of the analysts. I think we have already heard this morning the words of a national program officer who says, okay, our job is to find out what you need to do, your job is to implement it. This is about the finding out what to do bit in the first place, but not only that. By the way, if you don't understand this logo, don't worry, you can perfectly survive without this. So what we do is we ask our students to work in groups, like if you are around one table, all those around one table, they're going to concentrate on one disease. And as you can see from this, this landscape, there is quite a number of diseases that have gone through this process. In black, you will see the ones that are usually regarded to be infectious diseases, measles, hepatitis, syphilis. There are also among these a number that are vector-borne, like Chagas disease, schistosomiasis, malaria, dengue. But we also do this exercise on what is usually understood nowadays under the term non-communicable diseases like diabetes, obesity, eclampsia, breast cancer, and that kind of thing. So it's the methods as in the course of time proven to be applicable to not all but quite most health problems. What is the structure? Okay, it is classically, as we do it, it is a 7-step procedure. You start with the importance of the problem. That is about suffering, the severity and the frequency, and the cost, economic and social. So that is, let's say, to get an idea of how important is this health problem. The second part, and that is probably, let's say, the skeleton of the whole thing, is how does this disease behave in a population? That is what we call the epidemiologic model, or if possible, the epidemiometric model, which is composed of different things. I am not, we don't have time today, I think, to go into the detail of all these things. But I think most of you already have some idea about this. And then on the basis of the second point and the first, we ask to select, to make a list of interventions that can act on this, what we could call disease system. How can we intervene on this epidemiologic model in terms of, well, with a selection of interventions based on criteria like efficacy, effectiveness, cost, and not to forget acceptability. So it's not what I would call a single metric type of exercise. It is something that tries to combine, let's say, the human aspects as well as the technical aspects of it. As you can see, these 3 points are slightly separated from the rest because they are actually, conceptually speaking, a little bit different from what follows. What follows is an attempt to, after having chosen these interventions, to try and formulate strategies to implement them. And this is only, let's say, leading questions that we propose. What kind of services do we need for that kind of thing? For the interventions that you propose, should they be as decentralized as possible or not? Should they be multi-purpose services or specialized purposes? Should they be periodic or permanent? What kind of personnel do you need for these things? Okay, you can apply the previous criteria to that, but in addition to that, you can apply, do we need highly qualified or not qualified or less qualified personnel? And then if we know all this, we know what to do, we know what services, we know what kind of personnel, then we can try to operationalize all this by asking the question, who does what, when, with what, how, where, to what purpose, etc. So this would be the final formulation of the program. And then intellectually, again, separated from the rest, we have step number 7, which is how would you evaluate what you are doing? So if we try to group these 7 steps, and actually for your comfort or discomfort, I don't know, but this is actually not much more than structured common sense. This is how we can try to conceptualize the formulation dynamics of a disease control program. But even if it is only structured common sense, the structuring is needs to be adequate. It needs to be something that makes sense. So the first 3 parts actually are quite general. And the sources of information there are mainly those that can be found in the internationally available literature. They're supposed to be general conclusions, they're supposed to be universally applicable principles based on the available evidence. By the way, I've been doing this for more than 20 years. That's why in the title you can see two decades of experience. And you might expect that if you listen to presentations of this kind year after year after year, you get bored. I can assure you this is never the case. Because what these students unearth and what they find and what they think should be done is different every year. We always learn. Now, after having done this, the second part is actually different. The second part is not or cannot be universally applicable anymore. The implementation parts 4, 5, 6, and part of 7, they need to be contextualized because, okay, there are huge, we have a very international audience of students, so they come from all over the place. All over the place means with very many different levels of resources, with very many different levels of competence, etc., etc. So, well, even if these are only the superficial elements, if you might say, of context, it is not possible to implement or to imagine the implementation of a theoretical disease control program without putting it adequately into context. Now, if you look at this thing, you might get the impression that this is a straight and linear process of reasoning. But actually, if you try to do it, and if you try to do it well, and you go systematically through step 1, 2, 3, 4, 5, etc., you will notice that each new step creates new elements for reconsideration in the previous one. So, in actual practice, the way this thing, this exercise works is an iterative process. People try first number 1, okay, then they try number 2. 1 and 2 are the basis for going to number 3. But once you get to 3, you find out, I need to know still something more detailed about number 2 before I can fully do number 3, and so on and so on. We give them usually about 2 to 3 weeks time to go through this process. It's not a full-time exercise, but it's spread over 2 to 3 weeks. Just to give you an idea of what kind of models they come up with, this is a model that one of our student groups produced about measles. Yeah, well, you have a non-infected, non-susceptible population turning into a non-infected, susceptible population, which can be infected and so on. I'm not going to go into details, but this is the kind of reasoning that is being applied. It is based on the natural history of the disease plus, let's say, the probabilities of transition of going from one stage in the natural history to the next one. And then sometime, well, okay, in this case, they were friendly enough to borrow me this, to lend me this presentation, their presentation. They insert possible interventions on this model, and they say, okay, what can we hope, what can we expect these interventions to produce? For example, non-measles related mortality reduction, measles related mortality reduction, vaccination, has to be done on these people within 72 hours, that kind of thing. Another model here, syphilis. Again, I'm not going to dwell too long on this. This is, I think you get the hang of it. This is the kind of model, it takes some time. The construction of a model like this, if you want to base it on really, let's say, valid, internationally available evidence, is not such an easy exercise. It is something that takes some time. And as you can see, this is also another model about syphilis. The presentations are sometimes quite different in how they look. Now, what are some generally observed regularities? If I try to do some meta thinking about this exercise, what would I have withheld as lessons learned? These are not really lessons learned yet, but these are regularities that seem to come up very very regularly, otherwise there would not be regularities, of course. Generally, students appreciate this exercise very much. Not all of them, but generally most of them do. The second regularity, on which I will come back a little bit later, is the almost automatic tendency to maximize. We will come back on this. I will explain what I mean by this. But it's also, and this is also almost, well, it's always the case, it is very difficult to critically assess the evidence that is available. These are not, let's say, researchers by trade. These are people, these are operational people who are doing an exercise in critical assessment of evidence. And then there is this mysterious thing about the sensitivity-specificity balance. How, most of them being doctors, how they deal with this, the balance between specificity and sensitivity. As a learning experience, ideally, of course, it really is a challenge to the powers of reasoning. I have done this exercise myself as a student. This was in 77. I remember I was almost addicted to it. This is really a very stimulating and a very challenging type of questions that are being asked. And making all this reasoning explicit, but using the arguments that are based on the best available evidence, coupled with, and that is also quite important, coupled with a measure of common sense, this is really what is necessary in order to be able to carry on some kind of fruitful dialogue. The reasoning, the arguments from going from the available evidence, part one, if you recall, to part two, how are we going to implement this? This is really not so easy. This is something that is not always, and actually rarely is, based purely on rational thinking. It is much more based on what I would call reasonable thinking, and sometimes only on a measure of plausibility. You just think this is probably the best way to do it, taking into account this and this and this and this and this. Another thing that is didactically interesting about the exercise is that if you do a variety of diseases for a group of students, if you have, for example, 10 diseases in a class, and they all present it, this gives you really the opportunity to discuss a very wide range of public health concepts. Especially if you make the mix of diseases sufficiently interesting. For example, a non-communicable, a communicable, a vector-borne, all these things, they offer opportunities to do a lot of discussion about public health issues. Ideally the previous slide was the ideal. But not everyone lives the experience that way. There are not very many of them, but there are, and they cannot be ignored, there are people who afterwards say, this was a lot of time spent to learn only a little more than I already knew. The interpretation of this kind of, let's say, failure, if you like, in the didactic process, I like to think that it is because not everyone catches on with this idea of the second loop learning. I think most people who like it a lot, they have discovered that they learn how to learn. The ones who are not very satisfied with it, I think they have missed out on that. Very often that is the case. But of course, it is reasonable to understand what they are saying because it takes a lot of effort and it takes a lot of time. Now, I think this is maybe one of the more central slides of what I'm trying to say today. This tendency to maximize. If you study a disease with the explicit purpose to formulate a program, it almost invariably ends up with highly ambitious programs. It almost always ends up with eradication. And okay, I'm not a psychologist, but I have the impression that there is some kind of identification mechanism that is at work. You start, in the end, you start to identify with this disease, and okay, it's a little bit like, I'm sorry, Katja, but I have known some helminthologists who spend their lives in eradicating helminths, but who are secretly in love with helminths, who like their subject so much that yeah, they can talk for hours and hours about worms. Now, if you concentrate on one disease, it is quite possible that this kind of, I admit this is almost a joke, but I think the process is something like this. You want to really get rid of this problem. And that leads to the selection of almost always the most ambitious program objectives and the most recent control strategies in terms of efficiency. The latest technology, the latest publications. Publications of 5 years ago, they are totally worthless. There is nothing in it. They only systematically use the really last fashion. Usually I let this go because, okay, there's not so much you can do about it, but at the end, when all these highly ambitious programs have been presented, my reaction is usually this one. Imagine you are in charge of a district or a sub-district, let's say the unit that tries to coordinate all healthcare and all public health activities, and it is expected of you that you maximize the insecticide-treated bed nets coverage, which is necessary. That you eliminate polio, which is also necessary. That you eliminate measles, which is coming. That you maximize cervical cancer screening, immunize all children, be prepared for epidemic meningitis, maximize 6-monthly vitamin A distribution, the TB detection and treatment, and so on, and so on, and so on. And in some of these really bad urban, rural districts in some of places of the world, all of this is available. You have to do all this, and at the same time you have to see to it that people who are sick get good care. Would it not be a possible solution, not a solution, but would it not be a possible alternative to try and scale down your ambitions just a little bit? The second irregularity, the difficulty of assessing the evidence. The problems there very often, and this may be a little bit contradictory with what I just said on this maximization bias. The problem may be the sediment, or what I call the sediment, of what one thinks one already knows. So people who have already some field experience, they say that I know how to do this. We've been doing this for quite a number of years already. And in other words, this is how it is being done. And that is not the purpose of the exercise. The purpose of the exercise is now we think we know how it should be done. And going from one attitude to the other attitude, to the now I know, I think, how we should be done, this is not so very easy, especially for people who have a lot of experience. And added to that, and this is a very, well, this is almost inevitable, but it is a very common thing that we observe. That is the power of conviction of the official documents of the expert committees and the guidelines. It is very difficult to question these, apparently. If the experts say it should be like this, who am I to say that it should be different? Now, of course, if you could rely always on the experts, you do not need to investigate the evidence. That is. And then there is, okay, this is not universal, but this is something that happens a lot with, when we do the exercise with people who have a lot of experience in clinical practice. And this is based on a difference that you can observe between another profession, the profession of judge, and the profession of medical doctor. Judges are being brainwashed into an attitude of, I do not want to condemn an innocent person. Which means they want to avoid, in our jargon, false positives. Doctors are brainwashed entirely in the opposite direction. You are not allowed to miss a case, which means that you actually cultivate a psychiatric fear or angst for false negatives. And this is something that runs very deep, especially for good clinicians. They are being judged as good because they never miss cases. But when they go through this exercise, where they have to think in terms of populations and, let's say, generally applicable strategies for entire populations, some of them get stuck in what I call the exceptional case possibility. Should I test all children on HIV because I want to be sure that they are not immunocompromised before I get them some kind of vaccination or things like this? This is what I call insisting on unreasonably sensitive tools for program standards. This is so far only about the first part. The second part, the implementation, actually we need supplementary tools in order to do this well. In the toolbox of our tradition, we have two of these tools that are quite, let's say, with which we have a lot of experience, and that is the operational analysis and the learning cycle. I'm not going to too much detail on this. The operational analysis is something that has been invented by a Mr. Pio, who was a TB expert at WHO in the 60s. And if you find the time, you can look at this at your ease. It is about a sequence of concepts that apply to what a patient goes through before he gets cured of TB. He needs to be aware of his illness, he needs to be motivated to contact the service, the service needs to do an examination. The sputum smear examination has a certain sensitivity, it also has a certain reliability, etc., which means that you lose a lot of people on the way. Another level of implementation, we also have another one, which is what I call nowadays the systematic learning cycle, which I'm very sorry I don't have the time to go into detail either. But it is, it is systematically, maybe the gist of it is that every intervention is actually based on a decision that should and must be formulated as a hypothesis, and this hypothesis deserves evaluation. Actually, science works this way also, but everyday learning also works this way. The only difference probably is that in science we try to be as rigorous as possible in the inference part, which is the red arrow that you see there. In later years, we are combining this with one of these concepts of what is called realist context mechanism outcome configurations, which is one tool to conceptualize, let's say, the difficulty of explaining why interventions sometimes work in one context and they do not work in another context. And the basic question that needs to be asked here, and this is an evaluation question actually, is not just does it work, but the question would become how does it work, for whom, why, and in what kind of circumstances. This question is a lot more difficult to answer, of course, but I think it sort of goes in parallel with what my colleague Fedi Sengoba has been saying a couple of minutes ago. You need to ask also the how question. It is not only the does it work question, but how does it work? And this how does it work is probably much more difficult than establishing that something works. Now, if you look at all this from the didactic point of view, you could ask yourself, is it really reasonable to expect that a master student can learn what I call to keep all these balls in the air? Because you need quite a number of different and complementary models in your head in order to arrive at the best possible program formulation that you can get. And I am tempted to ask if we could even expect this from professional researchers. It requires not only depth of expertise and knowledge, it also requires breadth of knowledge. Again, I think repeating more or less what Freddy Sengoba has been saying. This is the last slide. What can we learn from this, or what did I learn from this? You do not necessarily have to agree. If I may extrapolate from the students' attitude to other and real-life disease control program managers or designers, watch out for the maximizing bias. Okay, many of them will have sufficient experience to be aware of this, but not all of them. Beware also of the balance between a program that needs to be reasonably stable. This is what the implementing actors request. They do not want to change every week. But on the other hand, you also need to adapt it to the latest evidence-based state of the art, keeping in mind that constantly changing state of the art does not always or necessarily mean that it will be much better. Okay, this requires wisdom. I'm sorry, this is not something for which there is a test with a p-value. And maybe one of the most important things that come out of this kind of ruminations after so long experience with this kind of exercise, if you are designing a program, please, maybe I'm preaching for the converted, but please involve generalist program implementers whenever possible and as soon as possible. This is not only for disease control programs, this is for any policy design, for any policy formulation. We see too much of this not happening. If it needs a justification, let's say generalist program implementers usually have a somewhat different but equally relevant way of looking at things. They're not in the same metric, they are in another metric, but these two need to meet. Otherwise, I think we get not what we want. I thank you for your attention.
Thank you. Do you hear me? Yeah. Thank you, Guy, for this interesting presentation. I think I participated a few years in this vertical analysis as well with the students on schistosomiasis, and I'm one of those helmintologists. It's true that every year it was a different experience, so I like the analysis that you made of it, and then the extrapolation, if we are allowed to do that. So I think we start with a provocative question.
It may be not very provocative, but trying to find out from you, as you know, you feel, what's your view when a particular program is being designed by involved parties? That means it could be the program implementers, it could be the program designers, the funders. These are the interested parties, and these parties have a particular set of objectives, and they will like to go in a particular direction only because of the fact that they have conceived something based upon their experience, based upon their preconceived ideas. So they are not very keen to look at the different angles of that. Is this something which is your experience? This is one issue. And second point that I would like to know, and I want to really comment on this, that you said involve generalist program implementers, I feel it is not only the implementers, even for designing stage, if you involve the generalist as well as, at least in the Indian context, I sincerely feel that when any program is being designed, involvement of the community leaders, involvement of the community in whatever form that you can think about it. And I have seen that no amount of technical expertise or no amount of academic expertise can replace that kind of an perception of a community that comes out from the community leaders, including the politicians. The angle in which they look at the issue is definitely many times different than so-called experts. So I'd like to have your comments on these 2 points. Thank you.
Well, thank you very much for these points. Well, this could go far. Your first question was about interested parties in world actors, if I caught your terminology okay. Unwilling, that's my decoding of your question, unwilling to go as broad as I think they should go. Is that more or less what it is? Yes, this is a very big problem. This is about what I call the conflict between single metric logic. This is, if you look at funding agencies, what they are interested in is cost effectiveness. They will formulate, okay, I'm generalizing too much, but just to make the point clear, their tendency will be to express the problem in terms of the single metric cost effectiveness. Program managers, program designers are probably going to see it much more in terms of effectiveness. Implementers are going to see it maybe in terms of equity. The public is going to ask, what am I gaining with this? And this leads immediately to your second remark, I think, in designing the implementation and in designing the intervention itself, the local stakeholders' perspectives are, of course, extremely important. But, excuse me, but go tell this to a national disease control program officer. This is probably what needs to be done at the local level. So let's say the basic principles of the intervention need some level of generality. That is, we cannot avoid this. But at the implementation level, there should be sufficient freedom, of course, to adapt these general principles to the local situation. Again, these are just general principles. But as to your first remark, this is a constant struggle. And I do not really know how to ensure the makings of an environment in which these different people using different single metrics will be willing to listen to each other.
Thank you, Professor Kagel. We have unfortunately run into issue of time management. We are running a bit late. So if there are any burning questions, 1 or 2, we'll take it up. Otherwise, we'll go for the next presentation. Any burning question? Any specific? I'll request you, if there are more clarifications to be sought from Professor Kagel, you may be able to talk to him during the dinner or prior to, immediately after this session is over. So thank you very much. Shall we go for the next presentation now, please?
Okay, the final keynote speaker will be Melissa Parker. Melissa has a BA honors degree. Is it working?
Yeah, that's what.
Really? She has a BA honors degree. Oh, no, it's working. In human sciences and a doctor in philosophy and biological anthropology, both from the Oxford University. Her doctoral research involved living in rural northern Sudan and undertaking more than 2 years fieldwork on the biological and social aspects of schistosomal infection among women and children. Since then, she has undertaken research at the London School of Hygiene and Tropical Medicine and Imperial College on a wide range of topics which fall broadly within the remit of global health. She has been working on the control of NTDs in Uganda and Tanzania since 2005. Now she works at Brunel University, and soon she will be appointed as an associate professor on medical anthropology at the London School of Tropical Medicine and Hygiene. She's going to present a very interesting talk with the title, which is also very interesting, Politics and Anti-Politics of Neglected Tropical Diseases. Thanks.
Thank you,
Yeah, this is a very interesting title at least, and unfortunately we will not be able to discuss much more, but we will like to, because the topic seems to be quite exciting.
Yeah.
Please go ahead.
Well, it builds very much on the previous talk. Is this working? Yeah. Okay. Last January, a debate took place in the UK House of Lords. In the course of the debate, the Earl of Sandwich and Lord Ray challenged the British government's decision to spend £250 million handing out tablets to control neglected tropical diseases. Citing research I've undertaken with Tim Allen, an anthropologist from the London School of Economics, they asked the Minister how she intended to resolve the difficulties we had highlighted. In so doing, they were, of course, also querying the merits of global policy sanctioned by the World Health Organization on the control of NTDs. So my talk today asks, why is it that ethnographic fieldwork undertaken at various sites in Uganda and Tanzania has generated such debate? And what are the implications of the research we have done for the design of NTD strategies more broadly? By way of background, many of you will know that over the last 10 years, more than $1 billion has been poured into the control of NTDs from donors such as the Bill and Melinda Gates Foundation, the UK Department for International Development, and USAID. In addition, a number of pharmaceutical companies have donated hundreds of millions of tablets free of charge to control NTDs such as schistosomiasis, lymphatic filariasis, and soil-transmitted helminths. Much of this money has been channeled to sub-Saharan Africa, and it's provided a real opportunity to design and implement national control programs in countries that have not had the resources to do so in the past. Now, all these programs involve the mass distribution of drugs free of charge to adults and children living in areas where the diseases are endemic, irrespective of whether or not they're infected. And there's a huge amount of optimism about the impact that NTD control can have for poor, neglected populations. Thus, Professor Molyneux and colleagues write, "Controlling Africa's neglected tropical diseases is one of the most convincing ways to make poverty history." And Sachs tell us, controlling the NTDs is nothing less than healing the world. So it's against this backdrop that Tim and I have been working on programs attempting to control schistosomiasis, soil-transmitted helminths, and lymphatic filariasis in Uganda and Tanzania. Funded by the Gates Foundation, we were part of a multidisciplinary group working alongside parasitologists and vector biologists from a London medical school, as well as with colleagues from ministries of health in Uganda and Tanzania. And this is just a slide of some of the sites that we've been working in since 2005. And we started off in northwestern Uganda in Panyamor, which is at the northern tip of Lake Albert, then returned to Uganda in 2008 and 2009 to work in Moyo and Adjumani districts, which border South Sudan, and Busia district and Bugiri district, which are close to the border in Kenya. And in 2007, in Uganda, I should add that we were working on schistosoma mannsoni and soil-transmitted helminths and the impact of mass treatment on those infections. In Tanzania, Tim and I did substantial fieldwork in northeastern Tanzania on lymphatic filariasis and soil-transmitted helminths and the impact of mass treatment for populations there. While we also had master students working in Ukerewe Island on Schistosoma mansoni and PhD students in Morogoro region working on Schistosoma hematobium and onchocerciasis. And we've had a large group of people helping with us over the years, 14 master's students in total and PhD students as well. And we've worked in around 150 villages collectively. So I obviously can't present all the findings from this work, but when one collates it, it's maybe not that surprising to discover that what emerges very strongly is that a single policy formulated in Seattle, Washington, and London, and then legitimized by the World Health Organization, cannot be rolled out in a uniform way across countries. And that the social, the political, and the economic issues profoundly shape the uptake of drugs at a local level. In northwestern Uganda, for example, research undertaken among the Ilur between 2005 and 2009 on schistosomiasis, or Heartsea as it is known locally, suggested that there was widespread fear and suspicion of the Ugandan government's attempt to distribute drugs. In part, this was due to long-running historical and political conflict between populations inhabiting the north and the northwest and President Museveni's government, which is strongly represented by people from the south and the southwest. But whatever the reasons, fear and suspicion was expressed in multiple ways by all kinds of people, including local politicians, traders, fishermen, ajogas, which are local healers, and herbalists. And the following quotes capture some of their concerns and fears. A 35-year-old fisherman, for example, told me, "We fear the drug. It is strong and powerful, and it's not wise to take it unless you have food stored in the house. This drug can knock you out for more than a week at a time." Others articulated fears of infertility. A local politician, for example, said, "The treatment for bilharzia can cause a woman to abort, so women particularly are afraid to take praziquantel. Women want to give birth frequently, and they think the ministry wants to reduce the birth rate in this part of the country." And still others expressed concerns that the drugs were killing people. A 40-year-old fisherman, for example, said, "People died from taking the drug. They were not sick before. We knew of 3 people that died." Now, interestingly, the fears and anxieties with mass treatment programs in this particular part of Uganda actually resonated across many, if not most, of our research sites, both in Uganda and Tanzania. In fact, in 2008, it provoked riots, with one of my PhD students having to be rescued by armed police. And this is a picture of the school that was destroyed. She was actually observing teachers at the time handing out praziquantel for the treatment of schistosoma hematobium in Morogoro region. Now, part of the problem, at least in Panyamur, was the enormous gulf between biomedical understandings of schistosomiasis and local understandings of Heartsea, or Akudi Heartsea as it's known. For whether you were talking about etiology or the signs and symptoms or appropriate therapeutic pathways, there was little point of overlap. And all of that's compounded by the enormously limited and ineffective communication that was taking place between those handing out the tablets through the Ministry of Health and those who were on the receiving end of it. As a consequence, many of the villagers who were handing out the drugs had absolutely no idea how to answer these kinds of questions, which people in villages often ask them. Well, why should I take the tablets when I feel well? Why do the tablets need to be taken by everyone once a year? Or why do some people suffer serious side effects and others not suffer any? Or what is the point of taking these tablets when I'm only going to go back in the water and be reinfected again? All very, very good, important questions. And it's very telling that virtually no one in this particular part of Uganda knew what the appropriate answer was, nor therefore how to convince people to consume them. There was also much too much reliance on voluntary drug distributors, with economic constraints often preventing people from distributing drugs. So many people didn't have the opportunity, I suppose, even to reject them. If you're a drug distributor in this part of Panyamor, and you've maybe spent 3 hours collecting water in a day, another couple of hours looking for firewood, and you have 6 children to feed, why would you walk to a homestead 3 kilometers up a mountainside away to find a family that you barely know to hand out tablets that you know are widely feared? It would make no sense. And that very small example highlights, I think, a further problem, that the whole program is premised on a very mistaken understanding of community. It assumes, if you like, that a sense of goodwill extends to all residents equally. In Panyamor, as with many other places in the world, this is absolutely not the case. So with all these multiple social, political, economic, and historic issues there influencing the uptake of drugs, when we looked at the actual uptake of drugs, we were not terribly surprised to find that in a large number of cases, the uptake of drugs fell well short of the actual targets required to have any chance of controlling infection. So the figures here on this PowerPoint slide have been derived from, we did a 10% sample of households of 14 of the 49 villages that make up Panyamor sub-county, went around and asked people if they'd received the tablets. Much more complicated to find out, even if they'd received them, if they'd actually consumed them. So this is simply about receiving them. And as you can see, by 2000, although in 2004 it looks quite like promising levels of drug uptake, by 2009 numbers have fallen hugely, and we're looking at really very low levels of uptake. 33% in one part of the sub-county, 36% in another, 59% in another. By way of contrast, the uptake of drugs for the treatment of schistosomiasis and lymphatic filariasis was much higher in Adjumani district, which borders with South Sudan. And you can see in some places on this slide, this again is based on actually on a 20% random sample of households of villages close to the River Nile. But in some places, the uptake of drugs reached 100% and 70%, 94%, 89%, and so on. So a very striking contrast to what we found in Panyamor. And when you're drawing on our own ethnographic research to try and understand these contrasts, it became apparent that there were really very specific social, economic, historic, political reasons that shed light on the higher uptake in Adjumani. So in particular, it was clear that the Catholic Church had a very influential role. They were very supportive of mass treatment. Indeed, they supported a wide range of public health initiatives, including immunization programs, child health days, and so on. And their enthusiasm for mass treatment was just part of a general outward-going progressive push to support public health initiatives. There's also a long history of disease control in this part of Uganda for trypanosomiasis. So there were mass treatment programs that were instigated to contain and control sleeping sickness dating back to the Protectorate period. And these experiences are still very much alive and talked about in this part of Uganda, and fed into a willingness to engage and think about the underlying rationale for mass treatment for NTDs. And then, because of the nature of political instability in this particular part of Uganda, there's considerable numbers of people living in internal displacement camps, and the regulation of life there both made it easy to access people, but there was also a willingness too that went with it to accept government donations to survive. And so praziquantel, the drug for schistosoma mannsoni, was just one of a number of things that people were willing to accept. So, we have this contrast, but just as the political, social and economic context shapes what happens on the ground in Panyamur in Nebi district and Adjumani district, so it also shapes the nature of debate, the way in which evidence is used and not used, and the kind of research that is done and not done on neglected tropical diseases. With hundreds of millions of pounds pouring into mass treatment, and accountability being to the donors rather than those afflicted with tropical diseases, there are, I think, intense pressures among those receiving grants to contain and sometimes silence critical debate. And these are some of the strategies being used in response to our research. Intimidating field workers. So in 2005, for example, when we first made our reports back to senior staff in ministries of health about the reluctance to consume tablets, the response was actually to send ministry staff to go and find our research assistants and intimidate them. Don't tell lies to those whites, they were told. Or it's your duty as a Ugandan citizen to say the drugs are working, even if they're not. Or if you carry on saying this kind of thing, we'll make sure you never get work again. Another strategy seems to have been the holding back of information, suggesting rates of reinfection are high in the aftermath of mass treatments. So we're well aware that only certain kinds of information, if you like, are being published. In many parts where mass treatment has been rolled out for 3, 4, 5 years, you'll find reinfection rates of 85%, 90%, 95%, but it's not being published. There's also the exertion of moral pressure to set aside information that may threaten funding and livelihoods. So I've always gone out of my way, for example, to circulate papers before submission to journals and invite many of our collaborators to participate and be authors on those papers. And the response has always been to try and persuade or cajole us to remove certain words, certain sentences, so at least the abstract looks positive or the conclusion sounds positive. I think in the hope that no one will read the middle bit. Veiled attempts to restrict access to field sites is another issue that has come up. And perhaps something that troubles me most of all is the misrepresentation of critical analysis in order to discredit it. So we published an article, I think it was in 2011, in the journal called Third World Quarterly, a social science journal, about the political economy of mass treatment. And much to our astonishment, a critique was published of it by Molyneux and Malekela in a biomedical journal called Parasites and Vectors quite soon afterwards. I don't at all in any way mind that they critiqued it, but the interesting thing about the critique was that they didn't actually engage with the substance of the argument at all. So it was a very emotional, emotive critique in which the paper, our work, was described as, without any explanation as to why, unethical and grossly negligent, disrespectful to endemic communities, and neo-colonial. Now, rather naively, I imagined when I began this work that there would be a willingness to refine health policy in the light of fine-grained ethnographic data. The reality, as you can see, has been rather different. Of course, a small but significant victory is the debate that occurred in the House of Lords last January, and the fact that I was subsequently asked to give evidence to the all-party parliamentary group on malaria and NTDs in London a month later. And it's not at all clear yet what all of this will mean in terms of designing future strategies for the control of NTDs. It is clear, however, that mass treatment in its current format cannot be rolled out in a uniform way across countries. That a single policy, if you like, formulated by the WHO in consultation with those based in Seattle, London, Washington, and so on, whatever they may wish, is actually undoubtedly going to be influenced by the political, economic, historic, and social context in which it occurs. Now, in different places, these processes are going to operate in different ways, but they undoubtedly have a profound impact on the uptake of drugs. It's vital then that anthropologists are involved en masse, both in the design and implementation of NTD control programs. For their fine-tuned understanding of the local context is clearly invaluable, not to mention their capacities to identify mistaken assumptions embedded in public policy. And finally, I think one thing that comes out of this work for me is the recognition how important it is to reflect on the way in which some of our most vocal advocates, some of the most vocal advocates of mass treatment present their approach. For it's presented as a highly technical, cost-effective, context-free solution to very, very complex public health problems. And actually, if you reflect on the strategy, one begins to see how the moral high ground has been seized, and how they're trying to present the work that we've done, as well as the work that's been done by Bruno Griesels and other colleagues at ITM, as they present it as unethical, disrespectful to endemic communities. And in so doing, they are, of course, also using a very pervasive anti-political discourse for their own very strategic purposes. So, forewarned, forearmed.
Thank you, Dr. Parker. As I anticipated, this is something which has a lot of connotations and angles, both political and anthropological points that you have brought it out. Are there any questions, queries that you would like to seek from Dr. Parker? Yes, a colleague on that side.
Thank you. I think it's very interesting, Professor Melissa, for such a documentation on what's work and what doesn't work. But my query to you, because you have implemented for, I think, 4 years in both countries, and the slide that you present in Uganda is not working very well. From year to year, the coverage is going to drop. But in South Sudan, it's working, it's working from years, it's increasing the coverage, the uptake of the drug. But is there any documentation-wise, in terms of contextual, political support, and the environment collaboration with other stakeholders, which have some kind of effect to the implementation? Is there any document on that? Because there is some kind of a long history of implementation.
The last point, can you please repeat the last point?
Is there any influence? Because is there any contextual support, environment support, political support, which have influence to the program implementation? Because the two countries are completely different.
In these two countries, because they are different from that political context. Yes.
I would love to work in South Sudan, but I've never done research in South Sudan, so it would be hard for me to comment on what's happening there. What I would say is, I don't know what the source of the data actually is, but in many of the places where we've been working in Uganda and Tanzania, the official figures would look as if the uptake of drugs is very high indeed. And you don't have to scratch the surface very much before the whole thing collapses like a pack of cards. And I think that, one begins to realize that actually, when you actually go out and find people and talk to them and so on, that one's often looking at uptakes of 15%, 20%, 25%. And that's not just coming from research I've done with Tim, but also by other people at other institutions in DBL and other places as well. So one has to ask, well, it's useful to reflect on those figures and look at what sorts of political, social forces shape the construction of those figures. What sorts of pressures are people under to say that the uptake is high? And actually, even just talking to, district officials, certainly in Tanzania, they will often say, well, we don't have a choice. If we don't say we meet our targets, then there will be pressure on us and our contracts won't be renewed and we won't get the drugs next time around, so we just have to make them up. So I'm not saying that's the case in South Sudan, I'm not saying it's the case everywhere in Uganda or Tanzania, but it is undoubtedly a real issue. I guess anthropologists are very good at looking at how those sorts of figures that are not impartial. They're shaped by political forces often.
Thank you. The last question, please. Yeah, or two more questions. Last on this. Okay, three questions. Yes.
Thank you very much for this interesting presentation. I think you made indeed a strong case to have, as you said, more involvement of anthropologists. Now, is there not a danger that anthropologists are being instrumentalized by the program to sell it better, to smoothen its rolling out, rather than at the expense of, let's say, independent, autonomous research? Is there not a danger?
Yeah, it's a very good question. I think one has to walk a tightrope as a way, because I think the most important thing is to maintain one's independence and separateness, because without it you don't have the option to be critically engaged and to put things out into important issues out into the public arena. On the other hand, it's also very useful to be a part of a program and to look for ways in which policies can change as the evidence emerges, so that you don't have to wait 5 years down the line for an article to appear to then think about what the implications might be. So I think it is possible to do both. I try to do both. It doesn't always work, but it depends very much on the mix of people.
Yeah, the one, and then Dr. Sogumba.
Thank you. And your observations and what you describe is, of course, context specific. And with context, I mean also related to the kind of drug that is distributed. But you recognize patterns. 40, 50 years ago, in the early vaccination campaigns, you saw the same phenomenon. 20, 30 years ago, when people were trying to eradicate Vivax malaria with mass drug administration, you saw the same reaction. Now then, my question to you as an anthropologist is, how come that policymakers and program designers do not learn from their past experiences?
It's very, very frustrating. I mean, I think maybe there's so many issues at stake, and it would be nice for there to be much, for many people to contribute to that question, because I think it's absolutely crucial. How much of it is to do with the different ways in which evidence is valued, that only certain sorts of data counts as evidence, the sort of reification of the randomized controlled trial we were hearing about earlier on this afternoon, pitched against this sort of ethnographic data, which can often be dismissed as anecdotal because it's hard sometimes to pin down how many people one spoke to or how representative they are of the general mass and so on. So I think maybe anthropologists need to grow up a little bit and be wise to the different ways in which data is used and to collect multiple kinds of data. So that's certainly what we've tried to do. We've tried to ground it in the ethnography, and then where we felt it was useful to quantify certain aspects of what we were finding out, to do that through randomized samples of households and so on. So that the combination then became very powerful and much harder for donors and policymakers to turn away from. Having said that, I think it doesn't mean there's some sort of incremental relationship between evidence, policy and practice. It's way more complicated than that.
Thank you. I want to add my voice to thank Dr. Parker for this. I think during the session when I was talking, there was quite a number of questions around context. How do you research context? And I thought that I wish I knew you were going to speak. I would just say, please wait for Dr. Parker to speak, because I think here we have kind of got some very concrete way to try and understand context, why in some place this is going up, in some place not picking up. And just to recap, if those people are still in the audience, the issue of course, the issue of culture on the ground, especially around donations, people are used to them, so they are willing to swallow them, at least where it went up. The social capital of the Catholic Church was there, the incentive of food, the population being captive in camps. All these are contextual factors that actually helped, from your explanation, to actually get these pills to be swallowed more in one context than the other. Having said that, I think I wanted you to comment on the methods that you carry out as anthropologists for the benefit of our audience here, especially to try and understand how these come up in your data and therefore become reasonable explanations to use. And lastly, a comment about data. Again, we in Uganda, because I come from Uganda and your study is there, but also globally, we know that there is a lot of incentivization of programs. And this incentivization of program comes, you have a grant, your management and the whole project is, their life is really wedded on it and its success. And generally the behaviors that we start to see in the whole system down is that data is no longer capturing reality, it's capturing the incentivization program. And I think many in Uganda and many other countries we have looked at some of this track, especially in HIV and even in immunization, we see data, habits around data that are no longer telling us, and especially can't use for surveillance purposes. It's more telling us about the incentive system that is being used around this disease control, and I think you illustrate that, and we are seeing it. And I think as system researchers, actually sometimes I don't believe in the official statistics anymore because of the incentives that we know are in the system that affect the data and how it is collected.
Thank you, Dr. Parker. And I think, friends, we'll go for now the next and the last but one presentation, short presentation. So 2 short oral presentations. Can you please introduce these speakers? Yeah.
The first one will be Julie Balen. Julie Balen is a lecturer at the University of Sheffield, School of Health and Related Research. Her research focus is on health systems research in West Africa. She did her PhD on schistosomiasis control in China, University of Queensland in Australia. And after that she did 2 postdocs on health systems in Asia. The title of her talk will be Barriers in Access to Control of Schistosomiasis in China.
Thank you. Let me see, is it working? Hello? Yeah, thanks. Thank you for the introduction. And thanks to the 4 keynote speakers for some really excellent and stimulating talks. Actually, listening to the speakers over the past day or so, I've noticed many parallels and yet also many differences. We work on a range of neglected diseases in various different countries and settings, but many of the underlying systemic barriers to disease control and elimination are common. So I'd like to tell you a story of schistosomiasis control in Hunan province of the People's Republic of China, focusing on inequitable access to control among the population at risk. You may be wondering why schistosomiasis, or schisto as we commonly refer to it. Schistosomiasis is a parasitic disease that is prevalent across more than 76 countries and territories in tropical and subtropical areas. There are approximately 207 million global cases, with another 779 million people believed to be at risk of infection. In China, the most recent national survey estimated that 800,000 people are still infected with schistosomiasis. Infections can be chronic and debilitating, and the disability-adjusted life years, or DALYs, which we heard a lot about yesterday evening, have been estimated to range from 1.7 to 4.5. Schistosomiasis is associated with human contact to infested water bodies that contain Chacaria released by the intermediate snail host. And these snail hosts, and here in Asia also the animal reservoir hosts, remain important contributors towards the schistosomiasis transmission cycle. It's a neglected tropical disease and a disease of poverty. In China, more than 210 million people were lifted out of poverty in the past decades as the country went through profound social, economic, political, and institutional transitions, and the centrally planned economy shifted to a socialist market economy. These changes created both opportunities and also challenges for vertical disease programs such as the National Schistosomiasis Control Program in China. And these vertical programs are considered particularly vulnerable to such changes. As we heard last night in the inauguration, neglected tropical diseases have a multifaceted nature of causation, and there is a need to understand this better in order to design and implement improved interventions and control programs. So, launched in the mid-1950s, the Chinese National Schistosomiasis Control Program, in fact, reduced the prevalence of infection in humans by more than 90%. Now, these are, of course, official figures, and we need to keep in mind what Melissa just spoke about in her talk. But this great reduction in prevalence was done through a multifaceted, integrated approach consisting of health education, environmental management, snail control, population screening, and large-scale treatment campaigns targeting human and animal reservoir hosts. But despite very clear accomplishments, substantial disparities have emerged among the target population. And on this map here, I have indicated areas which are still endemic for schistosomiasis in pink. So, within China, Hunan province is a highly endemic area, and this may be a result of substantial changes in human and animal population density, which is connected to a large water management project in the Dongting Lake area, shown here in blue, as well as daily water contact patterns of migrant farmers and fishermen. And preventive, diagnostic, and when necessary, treatment services often fail to reach the poor, the rural, and the most vulnerable populations living in remote areas that surround the Dongting Lake, the vast Dongting Lake. So in this, here's the Dongting Lake. In this work, we used the Health Access Livelihood framework proposed by Obrist et al., which identifies 5 key dimensions of access to healthcare, including availability, accessibility, affordability, adequacy, and acceptability of the goods and services offered by the National Schistosomiasis Control Program. We conducted document analysis, as well as in-depth interviews and focus group discussions with 79 advanced stage patients and 66 healthcare workers, all of whom were primarily involved in schistosomiasis control. From a historical point of view, we found that the availability of physical resources, such as, for example, the number of hospital beds, and human resources, such as the number of trained personnel, increased over time, although the prevalence of schistosomiasis actually decreased. And this historical observation suggests that this is largely due to the Chinese government's perceived public health importance of schistosomiasis, which was placed high in the political agenda and treated as a public or a semi-public good. Given the large decrease in prevalence over this time period, though, we suggest that some of these resources could now be put to use for other neglected diseases by broadening control efforts to include an expanded profile of parasites, such as soil-transmitted helminths and intestinal protozoa. Perhaps worryingly, we also found that preventive measures were less available than therapeutic services. There's a growing trend of advanced schistosomiasis among the young and the female and the mobile populations in Hunan province, especially those from low endemic areas, low endemic villages. Whilst risk awareness and chemotherapy was reported to be high among residents in highly endemic areas, the contrary was true for individuals, including health workers, from non-endemic or mildly endemic areas. These individuals were said to lack the awareness of key risk factors, such as contact with infested water, as well as disease-specific knowledge vital for diagnosis and treatment. And this inaccessibility of schistosomiasis control in some areas actually placed individuals at a higher risk of advanced disease and posed a heightened chance of reemergence. Poverty is a key social determinant of schistosomiasis, and we found that schisto patients were among the poorest individuals in the community. High medical expenditure actually accounted for a considerable proportion of their annual income, and most of these expenses were directly due to schistosomiasis. In fact, medical spending was 12-fold higher among the schistosomiasis patients interviewed than the per capita average in the area. Expenditures were highest for inpatient treatment, and perhaps as a result, most patients reported preferring outpatient treatment and buying medicine at the local chemists. Many said they would ask to be discharged from schistosomiasis hospitals once the symptoms improved marginally, and this is due to a lack of financial resources. About a third of the patients delayed seeking professional medical care, turning instead to cheaper forms of traditional medicine. And one patient actually stated, "If it is possible, of course I want to be treated, but I have no means since I have no money." And another said, "If you have money, you will use it to challenge schistosomiasis, and if you don't have money, you will use your life to pay for it." None of the patients had any form of health insurance, and all expenses were out-of-pocket payments, making affordability a major barrier. Though overall the patients reported that the services offered were acceptable, the health workers we interviewed pointed to inadequate resource organization and management and referred to gaps, highlighting that a lack of thorough training, together with limited biomedical knowledge, resulted in a poor quality of service provision. Many staff expressed a demand for improved technical expertise and efficiency at the grassroots level. One informant actually expressed it as follows: "More and more people enter anti-schistosomiasis system, but only a few get the professional training." Most patients reported that doctors and staff were hospitable and that they treated them well. However, they reported that when compared to the general hospital, the professional competence of the schistosomiasis doctors and nurses was poorer, as were ward conditions and the equipment used. One patient actually said, "The service attitude of the anti-schistosomiasis hospital is reasonable, but their techniques make us feel uneasy." So, notwithstanding the numerous limitations of this work, which a 10-minute talk doesn't really allow me to go into, this study has illustrated the importance of taking a broad approach to program and evaluation that links utilization and provision of health services with the wider context of health systems and health policy. The findings are of particular relevance now that China aims for schistosomiasis elimination. This study also highlighted ways in which equity in health services, which is characterized by universal access, depends upon the context, policies, processes, institutions, and organizations that govern health-related goods and services, as we've heard so much of today, as well as the capacity among individuals, families, and communities to accrue assets and make use of them in times of need. I hope I've illustrated how these affect one national control program of a neglected disease in Asia, and in the future such multi-layered systemic barriers could be taken into account in the design, development, implementation and evaluation of national disease control programs. Yesterday evening we heard that the diseases are not neglected because there are national control programs running, but I would also add to that it's the specific systems and the unique contexts within which these programs are situated which are in fact neglected. So I would like to acknowledge all the study participants and collaborators in this work, and thank you for listening. This has been published in PLOS Neglected Tropical Diseases earlier this year, in case you would like to read more, including some of the limitations which I didn't have time to go into.
Thank you, Julie. Thank you very much. I think, friends, what we will do is that we'll go for second presentation and open both the presentation for the discussion. Thank you, Julie.
Thank you.
The next presentation now. Yeah.
Okay, the last speaker of this session will be Severine Thijs. She works at ITM, Department of Public Health. And she also coordinates the strategic network of neglected diseases and zoonoses, of which we had a satellite session on yesterday morning. She has an MSc in anthropology and one in public health. She started to work at ITM actually already in 2009 in the former animal health department. And she did various studies on disease perception among livestock owners with a focus on zoonoses in 3 settings in Africa. And today she's going to talk about the added value of anthropological studies in neglected zoonotic disease control.
Okay, good afternoon everybody. Thank you, Katja, for the introduction. Indeed, I would like to continue to show you the added value of anthropological studies in the domain of neglected zoonotic disease control. I will do so through the brief reporting of 3 case studies. Maybe it will be 1 or maybe 2 according to the time frame. So about the aspect of neglected zoonotic disease, we already mentioned it, but I just would like to highlight the fact that neglected because of the effect on the poor and apparently even the poorest of the poor in the communities. Also because they are widespread underreported and because of the low prioritization in the agenda of national and international agencies. Now, the zoonotic aspect of this disease, so the particularity is that there are zoonoses, and those diseases are transmitted naturally from vertebrate animals to humans and vice versa. And because of this specificity, they present a huge amount of unique control challenges, mainly because of the animal-humans ecosystem interface where they are situated, and also because causing a dual burden on the communities by first compromising livestock health and secondly causing human morbidity and mortality. So that's how the One Health concept came back from its ashes. So it's now a new concept. It has been already existing for decades, but it came now back. So it's a fashion new, not new, but it came back as a concept. We don't have a final and unique definition of it, but the purpose of it is to promote the cross-sectoral and the collaborative efforts of animal and human health systems, and also to promote the multidisciplinarity approach to understand the complexity of ecosystems where animals and humans are coexisting. So what is the role in that picture of the anthropologist and the medical anthropologist in particular? It's, in fact, according to me, to improve the understanding of livestock owners, perception, attitude, beliefs, knowledge towards those neglected zoonotic disease in order to improve control measures and make them more adapted to the social cultural environment where when humans are living with. So that was one of the 3 main objectives followed by the strategic network of the formal one was on zoonotic disease, and now we merge and we are also targeting neglected tropical disease. Because at the beginning was the idea to understand what are the barriers that makes the control measure not working, not being efficient, and maintaining the disease in the environment. So they finance 3 main anthropological research. So the first one was in 2009 about the perception of hidatidosis or echinococcosis in Morocco. That has been done with a collaboration of the Agro-Veterinary Institute of Rabat. The second one was done in 2010 in Zambia. It was about cysticercosis perception with the collaboration with the School of Veterinary in the University of Lusaka. And then the third one was on rabies in South Africa, in the Mnizi community. And that has been done with the collaboration of the Faculty of Veterinary Sciences in Pretoria. The method used for the 3 studies was the focus group discussion. So I'm not going in details into the definition of this method, but just to remind you that it's an open, homogeneous group discussion with a number of people limited to 12 approximately. Homogeneous, I mean by that it's important that the group have a similar background on the topic you are targeted, and socio-demographic characteristics also. So these discussions are guided by a facilitator. The group members are really we are trying to make them talk freely and spontaneously about a certain topic, That's why we say focus. And then the main purpose of this method is to obtain really in-depth information on concept, perception, ideas of the group. The idea is not to know how many people think or have that idea, but more how many different ideas are existing in this typical group. So it's more than a question-answer interaction, and it's even more than the simply sum of individual interviews. But this method has got some limitations. The first and main one is that you can't generalize your findings to a larger population. First of all, because of the sample techniques that you are using, and most of all, because it's not at all the purpose of this method. Then you have the problem, the moderator can bias easily the responses by suggesting what he is waiting to hear, or also by acting like an expert. The neutrality of the meeting place is really important. You are not going to ask questions related to health behaviors or knowledge about disease in a hospital. That is completely not adapted. And then the results, if they are easy to collect it from the data, the analysis of it is really challenging. And if you are two different researchers, you can come out with two different results. So that's also something you have in mind. And then the translation issues for both of for the three studies. I was not fluent at all in the local language, so I trained facilitators to moderate the discussion, but then you are a bit reliable to them. And also after, when you transcribe and translate the discussion on paper, you can also have some issues. So it exists some technique to avoid or reduce those bias. I don't want to go through them, but I just wanted to show you that any methods are not perfect, and most of all, they will be more effective if they are really adapted to your research question. So a good tool will be, if it's adapted to your question, will be a good method. So now about the disease. The first one, it's about echinococcosis in Morocco. So it's a parasitical zoonotic disease caused by the worm Echinococcosis granulosus. In this study, we targeted 4 different groups: the men, so the livestock owners, their wife, then the butchers, and also some students. We were in an area, a rural area, where the population were mostly Berber, so they are not speaking Arabic. And it's a place where they are mainly doing sheep breeding, but extensively, and some agriculture. The question guide targeted 4 main topics: the perception of the dogs, the sheep management, knowledge and perception of this disease, and the perception of control options. So the result I choose to present to you is linked to this topic. I didn't explain you the life cycle of this disease, because here the results showed that there are differences between the real life cycle of the disease and the perceived life cycle. So mainly this worm infected humans and sheep, in this case, by creating cysts in the lungs and in the lungs and the liver mainly. And humans get infected, as the sheep also, by ingesting food or water contaminated by infected feces from the dogs. And then the dogs, they get sick asymptomatically, by, in fact, eating infected offals, throwing away in the abattoir or in the street. But that's the real life cycle. Then for them, they really are aware of the threat coming from the dogs. They even call the disease the dog's disease. They are also associated the cat with that. But even if they have all the different pieces of the puzzle, they don't really put them at the right place, especially they are really missing the fact that the offals are making the dogs sick and then contributing to maintaining the life cycle in the environment. So now the second case study was the cysticercosis in Zambia. We targeted also 3 different groups, men, women, and children. Why? Because we also think that the role in this case, in the pig management or even in the life in general, are different, are important to take in account. This population is a rural population also. We are among the Nsenga ethnic. They are, in fact, observing the matrilineal descent. I will explain why it's important that I mention that now. And then the question guide targeted the perception of the pig breeding, the knowledge and perception of the disease, the risk behavior, and principally the lack of construction and the lack of use of latrines. And then the opinion of some control measures. So one of the results are linked to the obstacles that we found out about the use of latrine. Here you have the main statement made and receiving a most important consensus among the different groups. And in bold you have the really consensus that were remaining in the whole groups. So the first one was the fact that not building one latrine and one house will be an obstacle to use latrine. That's obvious. But one latrine, they were really insisting to the fact of one latrine, because if there were 2 latrines, it was not a problem. And that's related to the main results. It's about taboos related to sanitation practices. There, in fact, mainly men are not allowed to defecate in the same latrine as their mother-in-law. And why? Because, in fact, when they get married, they have to live with the family of their wife, and normally their role is to build their own latrine for their own family. But according to the woman, they are too lazy, or it's because also they are most of the time in the field where there is no latrine anyway, so for them it's not a problem to continue to practice open defecation. So that was important, and there are so many findings about that, but just to highlight some points. And then the last case was on rabies in Africa. It's in a rural population, but the particularity is that they are living at the interface with the wildlife. And there are recently, there are epidemic for rabies. And so the veterinarian have got some difficulties to make them vaccinate their dogs. So the main interesting result I would like to talk about is how they perceive dogs vaccination. So vaccination for dogs in general, they are aware that they prevent dogs from getting sick and to spread disease, but it's also something that can kill the dogs, especially when your dog is too old. They don't know often against which disease they get vaccinated. There are so many rumors around these injections. The owner are also asking for more explanation from the vets, and the vaccination needs to be more regularly. That's coming, all the statements I made is coming from the people. And then specifically against rabies, there are a few barriers, and I will just mention the one. For them, vaccination is a plan for game lodges to kill hunting dogs. So they are using mainly dogs for security, for herding their cattle, but also for hunting. And the game lodges are not really happy that their dogs are getting into the park, because there are the fences. We are close from the Kruger Park. So we are in the Kruger Park. And then, for them, it's when a campaign for vaccination is coming, it's because the lodge managers ask them to come and, in fact, to kill their dogs. So that was some findings, but to conclude generally, I just wanted to highlight the fact that with social anthropological study, you can have a really huge amount of information about the reality of your population. It can also be applied in a really big range of domain. And be really useful. So now, according to the specific methods of focus group discussion, yes, it's really cost effective, and you can really collect good quality of data in a short period of time. But only use one method, it's not really, because of all those bias, you can really have some problem for your validity of your data. So it's really always good to, when you have a problem, to look at it in different angles, and that's how we come to the multidisciplinarity. Then we were mentioning that when you would like to apply your methods or your discipline with combined with other, you need to be to make compromise and maybe be more flexible, also according to your methods, and not be stuck to the way you learn how to do it. And then I know that a big issue is how to generalize, standardize local findings. I know that program managers, they are looking for something that can work for the most of the people, but when they ask why it's not working and you come with the why answer, yeah, but it's just for a local part of the world, and how to make it generalized, so we have still to work on that. Thank you for your attention.
Thank you, Suri. Friends, now both the presentations are open for discussion. If there are any questions, clarification that you would like to seek. Okay. Well, I think, yeah. Yes, please go ahead. Yeah. Please address it to one of these two young ladies.
Okay, thank you. I want to thank both presenters. This was very useful, especially in the way that this session, I think, is bringing up some core messages around how we can generate some information that can complement other and mostly what we would call standard program management information. And I wanted to thank them also for having displayed the value, especially that is in trying to understand beyond the data that we generally use in terms of disease control. So maybe the question is related to the statement that was made by the last presenter. I know it is very hard to generalize information from these particular studies, especially if they are looking in detail at the particular context. But how can, for example, if it is done in Kruger Park in South Africa, how can one walk to maybe Western Cape, trying to talk to managers there who are interested in this, to try to maybe inspire them to do the kind of work that you're doing? What might it take? Because I think it is an important aspect of how can we get this kind of information to be able to be generated in these different environments where it is needed.
Would you like to respond? Yeah.
Hello? Yeah. Yes, indeed. But well, it's possible to make some generalization. For example, in the case of the sanitation practices, when you see that the maternality aspect of the society has got a role on that, you can imagine and check if in other maternal society you can find the same taboos, the same barriers. And in the case of rabies, by showing that there are some barriers and that the relationship between the community and the lodge manager from the park are creating some rumors that affect the health of the animals and then of the people, that's something that you can bring up, and that's something that if you make advocacy of that, then you can convince other people to look more in details in their part of the, in their society where they want to understand. And the findings may be different, but they might be the same. But by showing that it has got an important effect on then your program and the way to implement it, I think they have to, if they are convinced, then we can look more in details in their situation. But there are some, I don't know if there are tools, but it's true that for the BedNet use, they try to have different shows. So if you order some BedNet against malaria, and you are in different settings according to the culture, you can decide, okay, for my country, I know that in this region I have to order non-transparent BedNets or etc. So it's maybe possible to be more creative in that sense, and I don't think it's costing much more money, because if you standardize everything and it's at the end not working, you lose all your money.
If I may just add to that, I think the kind of meta-thinking that Professor... Can you hear me? Oh, thanks. Just to add one or two words to that, I think the kind of meta-thinking that Professor Kiggles applied in his talk earlier can also be used in a way that if we take lots of different sort of learning from different places and try to create a kind of mutual learning in a way that isn't necessarily, you know, any longer specific to that situation, but it's been brought from that specific context, then we might be able to use that kind of higher level learning from these kinds of studies. Just a thought.
Thank you. Friends, we had very excellent presentations from the keynote speakers, Dr. Senguba, then Dr. Professor Venkatraman, then Dr. Guy Kegels, and Professor Melissa Parker, followed by these two oral presentations by Julie and on the zoonotic diseases by Dr. Theis. I think we have learned quite a lot, and realistically what are the situations and what kind of strategies or the areas where we could work out. And I personally appeal to Dr. Deva that the outcome of this entire thing will be try and putting, I know these are not, it is not essential that every presentation can be converted into a kind of an operational guideline, but the point that I'm trying to say that maybe after today, tomorrow, once this is over, we try to come out with a kind of lessons learned and lessons possible to be adopted. I'm not saying that it can be adopted, because the title indicates that it has Asia as a kind of a backdrop. But if we convert that into India, Karnataka, or say Odisha, I think then I feel spending these 3 days will be much more valuable than just going through this process of listening and enriching our knowledge. This is just a suggestion. Maybe it is putting little more work to you and to your colleagues, but this is just a suggestion. So friends, I wish to sincerely thank all the presenters, the keynote speakers, and the presenters for wonderful afternoon, even though I was apprehensive that post-prandial sessions will not be that interesting, but they ensured that they remain interesting, they became interesting, and all of us are awake from that time till now. Thank you very much.
Thank you. Thank you very much for those closing remarks. On behalf of organizers...
Sorry.
Yeah.
Kindly forgive me for not requesting my co-chair to have final few remarks also, please.
Please, Dr. Pullman. Yeah,
this happens.
I don't have any specific final few remarks. I just want to thank the audience as well, and thank you for the wonderful chairing that you did.
Thanks a lot.
So thank you. On behalf of organizers, I would like to thank Dr. Subhash Salunke for accepting to chair the session. Kindly accept a token of appreciation from our side. Thank you, sir. Thank you. Thank you so much. I would like to thank Dr. Katja Polman for co-chairing the session, treading a difficult path of managing time and at the same time providing space for interesting discussion. Thank you. We would like to thank Dr. Freddy Sanguba, who is now sitting down in the front, for interesting presentation, sir. We would like to thank Professor Guy Kegels for delivering a keynote. We would like to thank Professor Melissa Parker. Thank you. Thank you for your inputs, ma'am. Of course, we would like to thank Julie, Severine, and all of you for your engagement in the post-lunch session. Before we close the session, I have some important announcement to make, so kindly take note. There are feedback forms on your table, and the feedback forms are as per specific sessions. So on the top of the feedback form, a specific session number is indicated. So kindly fill out those forms and leave those forms on the tabletops. Our colleagues would collect it. In terms of presentation files of the speakers, we are trying to upload those files on the Colloquium website, but in case if any speaker has some restriction or they do not want to put the presentation files in public domain, kindly let our colleagues know at the desk on the right side, and they would not put those presentations up on the website. Of course, abstracts are available in the abstract book. There is a change in the schedule of tomorrow's program, so kindly take a note. For tomorrow morning session, that is session 4, which is a continuation of the earlier session, State of the Art of the Control of Neglected Diseases in Asia, Part 2. Now, this session was scheduled to start at 8:30 a.m. To rather make life a bit simpler, we are going to start it at 9 a.m. So the session will start at 9 a.m. and it will go on till lunch, because we have 8 speakers in that session in order to maintain continuity, which means that we had a session 5, which is dynamic poster presentations, which was scheduled to start at 11:30 a.m. We are postponing it. So that session about poster presentation will be post-lunch. So the session 4 will run from 9 a.m. to 12:45, that is just before lunch, and then we'll break for the lunch. Post-lunch at 1:30 p.m. we will have the poster session for 2 hours, so that's 1:30 p.m. to 3:30 p.m. And then at 3:30 p.m. we start session 6, which is control of neglected diseases and social determinants of health. This is not to neglect social determinants of health, but we had some cancellation of a couple of speakers, though I think the chair and co-chair have done an excellent job of managing to get video presentations of one of the speaker. And so I think we should be fine starting session 6 at 3:30 p.m. and closing it maybe somewhere around 5:15 p.m. or something. So that's the change in the schedule. And finally, about dinner today, there is, unlike yesterday where the dinner was served alongside of the meeting room, there is a special social event with dinner for alumni of Institute of Tropical Medicine, Antwerp, and that will happen on a 2nd floor, and that is by invitation. So and then for other delegates who are staying at Hotel Park Plaza, the dinner is arranged at 1st floor in a restaurant where you take your breakfast on a routine basis. So you have to just provide your room number and you can have dinner on the 1st floor. For those guests who are staying in Hotel Ibis, they can have dinner at Hotel Ibis on the ground floor restaurant. So with that, I thank you all again and wish you a pleasant evening. Thank you.